So next up, we have our research perspective. So we're going to hear from two of SOLACE's own board members who are also experts in the field in the United States. First, we have Dr. Cynthia Brumfield, who is a recently retired professor of OBGYN in the Division of Maternal Fetal Medicine at the University of Alabama, Birmingham. She served as medical director and quality director of the postpartum and antepartum units at University Hospital. Dr. Brumfield teaches the operative vaginal delivery courses in the Department of OBGYN and has had a long career teaching proper use of forceps and vacuum instruments and the prevention of third and fourth degree tears during vaginal or operative vaginal delivery. Dr. Brumfield is happy to be a volunteer at SOLACE and use her medical knowledge and connections to increase awareness and support for women who have experienced childbirth injuries. Her talk is titled Current Challenges in Reducing Obstetric Anal Sphincter Injuries. Afterwards, we will hear from Dr. Holly E. Richter. Dr. Richter is the endowed chair of obstetrics and gynecology in the Department of Obstetrics and Gynecology at the University of Alabama at Birmingham. She is professor of obstetrics and gynecology, urology, and geriatrics, past division director and current research director of the Division of Urogynecology and Reconstructive Pelvic Surgery. She is Associate Director of Gynecologic Research for the Center for Research in Women's Health and past President of the Society of Gynecologic Surgeons and the American Urogynecologic Society. She is the past Medical and Quality Officer of the Ambulatory OBGYN Clinics. She serves as an editor for the International Urogynecology Journal, section editor for Current Geriatrics Report, and past editor for Obstetrics and Gynecology. In 2019, Dr. Richter receives the Society of Gynecologic Surgeons Distinguished Surgeon Award. Dr. Richter has been principal investigator on many NIH and industry-sponsored research projects and grants, has over 391 publications, many in top journals, and has been recognized throughout her career with awards for excellence in research and mentorship. Prior to medical school, Dr. Richter and her husband lived in Niger. It has always held a special place in her heart, and after becoming faculty at UAB, she started to go to Africa to surgically help women injured in childbirth there. She has been to Zambia, Ghana, Liberia, Uganda, Sudan, and for the past few years has worked in Danja, Niger. She has a strong interest in treating vesicovaginal fistulas and has visited Africa regularly for nearly 20 years. Her talk is titled Childbirth Injuries at Home and Abroad, the Global Surgery Experience. And I am giving over control to Dr. Brumfield. Please go ahead.
Yes, thank you, Amanda, for the very nice introduction. I'm happy to speak to everyone today. I'm coming from a maternal fetal medicine obstetrical perspective. And my practice has predominantly been in the United States, so I will be talking mainly about United States obstetrics. And we're going to discuss the current challenges that we have in obstetrics in reducing obstetric anal sphincter injuries. Next slide, please. And next slide, please. Today, we're going to be reviewing maternal and fetal risk factors for the obstetric anal sphincter injuries, or OASI. We're going to discuss how recent recommendations to improve vaginal delivery rates might increase OASI. We're also going to review labor and delivery management strategies that may minimize severe perineal injuries. And then at the end, we're going to discuss implementation of one of our OASI care bundles for quality improvement. Now, why should we? Okay, yes, let me get the slides in order now. All right, so to discuss the anatomic definition, today we're going to be discussing both third and fourth degree perineal tears, the severe forms. The third degree tears may involve tearing of portions of the external anal sphincter or both the external sphincter and the internal anal sphincter. The fourth degree tears involve tearing of both the external and internal anal sphincter and the anal rectal mucosa. As Dr. Freeman said earlier, the incidence of these tears varies depending on who you read, between 1 and 7% of vaginal deliveries. But some studies have reported a rising incidence of these severe tears. Purpose of my talk is that I'm going to explain why we may be seeing a rising incidence. Next slide, please. Now, why are we concerned about these complications? Well, in the short term, a patient can have pain, edema, infection, urinary retention, fecal urgency or pain. In the long term, dyspareunia, wound breakdown, rectovaginal fistula, fecal incontinence, psychological distress, and chronic pain. Next slide. These are the classic risk factors for OASI. As you read down these risk factors, you note that there are maternal risk factors, fetal risk factors, and events that occur in labor and delivery. What is interesting is that the majority of the, at least United States population today, is going to have at least one of these risk factors. And many patients now have multiple risk factors. So that is what we're dealing with today. Even though you have a risk factor, doesn't mean you will get an OASI. Likewise, you can get an OASI without any risk factor at all. But it's interesting how these multiple risk factors all intertwine, and you'll see that as I go through these slides. Next slide, please. Now, this is a well-known graph showing the declining fertility rates and birth rates in the United States. Next slide. From the year 2022, we had approximately 3.6 million births. If you look closely into the statistics, the overall birth rate and fertility rates were declining in every group except women of advanced maternal age. The older women were having increasing in birth rates. So women are delaying childbearing. The mean maternal age at first birth was also increasing across all ethnic groups. And very interesting, it was the highest mean maternal age for women of Asian ethnicity. Next slide. And babies are getting bigger. This has been tracked since 1950. This study analyzed 29 studies, which has included birth weight data from over 183 million infants worldwide. And there's been noted a significant increase in term infant birth weight since 1950 of 1.46 grams per year. Next slide. So why are babies getting bigger? Well, certainly we have better prenatal care, but more women are delaying their childbearing to advanced ages. They're having their first pregnancy at an advanced age. They're becoming more obese and have a higher rate of diabetes. Next slide, please. Now, fetal macrosomia just means a large fetus, and it's really defined as a fetus really over 4,000 grams. And for those of you who think in pounds, that's 4,100 grams is 9 pounds. So it's around a 9-pound baby. The risk factors for fetal macrosomia are some that we had already mentioned: diabetes, obesity, advanced maternal age, and if you had a previous infant that was large. Next slide, please. So unfortunately, pre-pregnancy obesity is increasing, and we do have data and we do track it. Pre-pregnancy obesity in the United States rose from 26% in 2016 to 29% in 2019. Next slide, please. And unfortunately, we have an increasing incidence of gestational diabetes. This Also, this slide depicts the rising gestational diabetes incidence between the year 2016, which is in light blue, to the year 2021, which is in dark blue. Next slide, please. And big babies are difficult to deliver. These are some of this slide lists the labor and delivery complications from fetal macrosomia. You can have postpartum hemorrhage, of course, an OASI, shoulder dystocia, birth trauma. You can have a prolonged second stage and the increased risk to need an operative vaginal delivery. Next slide, please. Now, there have been some changes in labor management that may increase the risk of an OASI. Next slide, please. This is a well-known graph showing the rise in cesarean section rate in the United States. As someone who trained when the C-section rate was only 18%, I must admit that I've been appalled to sit there over time and watch the C-section rate rise, whereas the more recent data, it's consistently around 32% of all live births. Think about that. 1/3 of all women are having a C-section. And many of our national societies are very alarmed by this rise in C-section rate. A C-section is a major surgical procedure. It has both short-term and long-term complications to the mother. We're not able to get in great detail about C-section complications in this talk, but all obstetricians are alarmed by this rising rate, and there have been recent attempts to try to lower this rate. Next slide, please. So one of the changes was to allow a longer second stage. Now, when I trained, we set time limits for women who had epidurals. How long should they be allowed to push before you intervene? And we said 2 hours of pushing in multiparous and 3 hours of pushing in nulliparous. But in order to try to lower the C-section rates, our American College of OBGYN and the Society of Maternal Fetal Medicine said longer durations may be appropriate and individualize these cases as long as you're making progress. So now we're seeing second stages that may last 4 and 5 and sometimes almost 6 hours before delivery. Next slide, please. So in order to have more successful vaginal deliveries, you have to have your OB providers trained in operative vaginal delivery. Everyone knows that if safely done, it can be done more quickly than a cesarean. And so it would avoid that the complication of cesarean. Unfortunately, though, we now have a generation of younger physicians that are not as skilled in operative vaginal delivery. When I was in training, about 10% of our deliveries were delivered by forceps. Now, operative vaginal deliveries have decreased to where it's around 2 to 3% of all deliveries. Next slide, please. Now, forceps and vacuum are the instruments used in operative delivery. My bias is that forceps are a better instrument, and they're more successful in achieving a vaginal delivery. It is well known, however, that forceps use is associated with about a 2 times increase in 3rd and 4th degree tears. And that's very important as to the outcomes in subsequent pregnancies. If you get anal sphincter tear, the recurrence rate, even though low at 3%, it is higher if you have to use an operative delivery in a subsequent birth. Next slide, please. Also, it is very well known now that there is a strong link between anal sphincter injury and the persistent occiput posterior. presentation. Even though the incidence is only 5 to 12% of all deliveries, it is more common in nulliparous, and certainly if you have a large baby, which that's a more common risk factor now. Often the occiput posterior will resolve to OA before delivery, or the correct position, occiput anterior. However, if that does not resolve and it's persistent at the time of delivery, you have a 15 times higher risk of a severe perineal laceration. Next slide. This is just an ultrasound depiction. For those of you who are not familiar with what occiput posterior means, is the baby is really looking at the ceiling when it comes out instead of looking at the floor. Next slide, please. So the challenges in training physicians, if we follow the ACOG and SMFM recommendations, is we have to go back and train a new generation of obstetricians to be well suited in the techniques of operative vaginal delivery. We also need to be aware that occiput posterior presentation is a high risk factor for injury of the anal sphincter. So we should encourage identifying this early and trying to manually rotate. There is a technique of manual rotation to the correct position prior to delivery. Next slide, please. So what are some future opportunities for reducing complications from OASIs? Next slide. So I think every labor and delivery needs to develop a culture that attempts to reduce these severe tears and keep them at an absolute minimum. I'm not sure they can totally be abolished. I think we'll always have these because of all the risk, the patient changes in patient characteristics. However, if we can keep them to an absolute minimum, that's what we should do. So OB providers should be aware of these risk factors. When appropriate, they should discuss with the patient, informed decision making. OB providers need to be properly trained in the proper techniques of vaginal delivery and instrumental delivery. We need to adopt labor practices that may reduce severe tears, such as controlled pushing, perineal massage, different birthing positions. We need to avoid episiotomies. There needs to be ongoing workshops and proper techniques for operative vaginal delivery. And, when we have the rare OB emergency shoulder dystocia, they need to have shoulder dystocia drills in labor and delivery. We also should be identifying and teaching manual rotation of OP to OA presentation. I think all the OB providers for third and fourth degree tear rates need to be monitored. And they need to be told quarterly, these are your rates of third and fourth degree tears. Next slide, please. Now, finally, at the end of the talk, I'm going to go over an OASI care bundle that we did at UAB. We use this to optimize recognition of these tears, to standardize repair and postpartum care and arrange appropriate follow-up. Next slide, please. This was the study that we did. It was a group study. We collaborated with urogynecology, maternal fetal medicine, and our quality group, who was monitoring third and fourth degree tears for some period of time. Next slide. Now, this study focused on labor and delivery identification of third and fourth degree tears. And when the tear was identified, we wanted a standard repair. All of our providers were trained in the technique, the proper technique of repair of OASIs. We wanted the patients to get antibiotics. We preferred the repairs to be done in the operating room, so you would have good visualization. We had a standardized postpartum order set, and we also arranged timely follow-up, usually within 2 weeks of the injury. This follow-up was done in urogynecology clinic. We also followed a postpartum to see if any complications occurred. This study shows that we were very successful in giving antibiotics and the follow-up, and we had minimal complications. One thing that we did not achieve is, as in the post quality improvement initiative group, we had about 87% of these OASIs were third degree. And since the provider thought it was a less serious tear, they chose to repair it in the labor room, delivery room, and not go to an operating room. And so that's why that was not statistically significant. But we were very pleased that we had achieved uniformity in our identification and our techniques of repair and follow-up for our OASI patients. This now ends what I had to say. I'll turn it over to Dr. Richter at this point.
Thank you, Dr. Brumfield. And Dr. Richter, you should be able to take over the screen.
Okay, very good. Good afternoon, everybody. I'm very pleased to be here today. I'm going to provide a bit more different perspective with respect to injuries associated with labor. A little bit of a world view on this. These are my disclosures, and I have no conflict of interest. Mando doesn't seem to be going. Okay, so let's start off with a story about a woman that could be one of many, primarily in low middle income countries. She's 14 years old when she's first seen. She's now 15. She's number 6 out of 8 children. She lived in a village with her family, remote, very remote from health facilities, as many of these women are. Father was a farmer. She worked the fields. She had 2 brothers that the farmer could afford to send to school. When she was 14, she was married off. This was as seen as something that would help the family. The father would get a dowry. And she quickly became pregnant, continued working in her husband's farm as well, and eventually went into labor. Her contractions were very severe without a normal progression of labor. And as tribal tradition, herbal potions, insertion of various substances into the vagina was performed, cuts were made. These are all things that are typically tried in some of these remote conditions. 3 to 4 days later, finally, it was recognized that they couldn't handle this, and money was collected and raised for transport to a health facility where she was finally examined. The child had succumbed. She was transferred to another facility for a C-section. Not long after that, she found she could not control her stool or her urine. So this is pretty tough, but a very familiar study, familiar story for those of us that do go overseas and repair vesicovaginal and rectovaginal fistulas. These women are severely impacted. Next slide. So the learning objectives are, by the time we finish this talk, you'll be familiar with the development of a rectovaginal fistula and obstetric anal sphincter injury that can be associated with obstructed labor, as this young woman demonstrated. And so, in a way, there is a time where prevention can be put into place. That is, if she is able to get to a health facility where she can have a C-section, these things can be prevented. and in the US, where there are guidelines to help mitigate occurrence, as both Drs. Freeman and Brumfield discussed. We're also going to understand the anatomy associated with erectovaginal fistula and OASI and discuss evidence-based repair of OASI at home and abroad, both repair as well as management post-op. Next slide. Go ahead and punch through all those, Amanda. So what is a fistula? I'm starting with a fistula because this is something that some of you that have sustained anal sphincter injuries may have also had occur. It is an abnormal passageway or connection between two epithelium-lined organs that normally do not connect. For example, the bladder doesn't normally connect with the vagina. The rectum doesn't normally connect with the vagina, and there are other types of fistula as well. In the case of obstructed labor, these are seen more often in lower and middle income countries compared to the US, women undergoing labor, mainly because we have access to health facilities. Although I would state that in the early 1800s and before, this was not always the case. As you can see on the figure, examination of erectovaginal fistula, a finger is placed into the anal verge, and there's actually a hole there where stool coming down can actually move into the vagina. Next slide. Next slide. Yeah, there we go. And this is just a schematic sagittal view of a rectovaginal fistula. Next slide. So an obstetric anal sphincter tear in a patient, also known as an OASI or OAC, obstetric anal sphincter injury, refers to a severe perineal tear that occurs during vaginal childbirth. Sometimes these are associated with the development of fistula, sometimes they're not. The majority of the time they're not, if the anal sphincter injury is repaired well. It involves damage to the muscles that control bowel movements, i.e. the external and internal anal sphincters, and often result in what is called a 3rd or 4th degree perineal laceration. I'll show you what those are in a minute. The result of sustaining an OASI is the potential for facilitating, causing fecal incontinence if not repaired properly. And as stated previously, this is considered a significant complication of vaginal delivery. Next slide. So let's look at a few key points about obstetric anal sphincter tears so that we're all on the same page. As many of you know, with respect to severity, they're classified as a 3rd or 4th degree perineal tear. Considered the most severe type of perineal trauma that occurs at the time of vaginal delivery. In lower and middle income countries, these are most often due to obstructed labor. In the US, they can occur during a vaginal delivery due to factors like large baby, prolonged pushing, forceps delivery, rapid uncontrolled delivery. These are all things that have been touched on previously. Next slide. So this is go ahead and punch through them all, Amanda. This is the standardized classification of perineal lacerations. A 1st degree tear, there's only tearing of the skin only. 2nd degree involves the perineal muscles, but not the anal sphincter muscle itself. The 3rd degree tear is broken down into various components. A 3A is where less than half of the external anal sphincter is actually torn. A 3B is where greater than 50% of the external anal sphincter is torn through. And a 3C is where both the external and internal anal sphincters are torn. And then next in severity is a 4th degree tear, which involves the external and internal anal sphincters, as well as the anal mucosa being torn. Next slide. So if we take a look at this figure, the first is a 1st degree tear. It's injury only to the vaginal epithelium as well as the skin of the perineal body. A 2nd degree tear is where there may be a tearing of the perineal muscles, the superficial transverse perineal muscle, as well as the bubble spongiosus muscle. Here demonstrates a 3A tear, so a tear in the external anal sphincter that is less than halfway, a tear that is greater than halfway, and then a tear that involves both the external and internal anal sphincters. This picture, as well as the one above, also shows an anal mucosal tear as well. Next slide. So let's talk about the repair. There are a review of the literature as a part of the care bundle that we put together at UAD. We did an extensive review of the literature to look at the evidence. What is the evidence? What does it show? And what does it hold for those of us that do anal sphincter injury repairs? In terms of repair of the anal mucosa, there's a variety of expert opinion with regard to technique and suture use. Some people do interrupted stitches to close the anal mucosa, others do a running stitch. And different types of suture, including vicryl, and different sizes of suture, including 4030 vicryls or 4030 chromics, have been described. And there's really no comparative study regarding suture technique or material for the repair of the anal mucosa. Next slide. When we talk about repair of the anal sphincter, there are two well-known approaches to repairing the sphincter. One is called an end-to-end, which, as you saw in the figure, if you've got the sphincter and it's torn, you're putting the two ends together, and then an overlapping repair where you actually overlap the muscles where it's torn. There have been some meta-analyses, one of 6 studies, almost 600 women, variable quality, that compared end-to-end repair versus overlap for a grade 3C or greater laceration, and found no differences at 12 months in the incidence of perineal pain, dyspareunia, or pain with intercourse, or flatal incontinence. However, a lower incidence of fecal urgency and lower anal incontinence score were observed in women undergoing an overlapping repair. The overlap technique has also been seen to be associated with a lower risk of anal incontinence symptoms over 12 months in another trial, but there were no significant differences in quality of life or in anal incontinence symptoms, either flatal or fecal, at 36 months after either repair. The only RCT that compared suture types did not find a difference between 3040 vicryl, PDS sutures for the sphincter muscle itself. No difference in suture-related morbidity or level of bowel continence or quality of life at 3 months. So expert opinion is that the use of 20 or 30 vicryl or PDS is acceptable. Next slide. So this is just we'll go quickly through this. This is end-to-end repair, and as you can see, basically you're putting the ends of the muscle together, and as a part of that repair, you kind of get the lateral connective tissue, which typically surrounds a muscle. This is a striated muscle on the external anal sphincter, and typically we'll do a posterior suture, inferior suture, superior and anterior suture to bring those two muscle ends together. Next slide. Okay, in terms of sphincter repair, what are the data with respect to antibiotic use? So in an RCT in which patients received a single dose of a second generation cephalosporin, either cefoxitin or cefotetan, versus placebo at the time of repair for OASIS, there were significantly lower rates of postpartum wound complications at 2 weeks with antibiotic use compared to placebo. In 2 cohort investigations at the same institution, intrapartum antibiotics were found to be protective in a retrospective and prospective study. So what this says to us is that it's very important that patients get antibiotics at the time of anal sphincter repair, and that second generation cephalosporins do a pretty good job. Wound infection and wound dehiscence in women with only OASI was 0.1 to almost 20% in these studies. Next slide. However, you would think that by this time there would be some kind of level 1 evidence for the use of antibiotics, but there's not. No randomized controlled trial has been performed to investigate the benefits of postoperative antibiotic use. So at this time, it's typically not recommended that the patient goes home with post-op antibiotics because antibiotics are not a benign medication. Next slide. So another important thing to think about after an obstetric anal sphincter injury, you want to avoid constipation. And randomized data have shown that the use of an oral laxative was associated with significantly less pain and earlier bowel movements compared to a constipating regimen. So recommendations state that stool softeners and/or oral laxatives should be prescribed to women who do sustain an obstetric anal sphincter injury. And counseling should also be directed toward discussing ways to avoid constipation. Expert opinion actually suggests the use of mineral oil and/or low residue diet to reduce the bulk and the caliber of stool. The mineral oil helping the stool slide out without having to push in the setting of a healing obstetric anal sphincter injury. Next slide. Pain control. As you can imagine, the use of narcotics only for management of pain with an obstetric anal sphincter injury would not be recommended, mainly because they're very constipating. However, there are some adjunctive therapies to use to both medications and non-medications. Ice packs have been associated with significantly less moderate or severe pain 24 and 72 hours after birth compared to women who did not receive treatment. Rectal suppositories, when compared with placebo in the first 24 hours after birth, did not influence patients' numerical pain score. However, the use and need for additional analgesia for perineal pain was reduced. Typically, rectal suppositories should be used with high caution so that there's no disruption of the repair. And NSAIDs and opioids certainly can be offered for pain control, but attempts should be made to help mitigate the significant constipating, well-known adverse side effects of opioids. Next slide. Urinary retention is a well-known outcome in women that have obstetric anal sphincter injuries. Up to 1 in 3 women may have urinary retention. So this is something that should be monitored in the immediate and short postpartum timeline so that it's assured that she's voiding well. Next slide. So in terms of hospital length of stay, there's no data that really determines an optimum of time to stay. However, that's kind of a joint decision-making in terms of pain and other types of factors. And expert opinion would suggest that the patient should be evaluated daily. In terms of initiation of pelvic floor muscle exercises, we know that the use of intravaginal as well as gold standard pelvic floor physical therapy may decrease postpartum urinary incontinence, but the effect on anal incontinence has been mixed. And there are no existing data regarding the efficacy, utility of post-repair pelvic floor muscle therapy and impact on long and short-term outcomes, which is remarkable. I would say that anecdotally, when I do repairs of anal sphincter injuries myself, both in relatively early OB patients as well as in women that may be a few years out, it just makes sense to me that the education and that a patient can receive regarding pelvic floor PT pre-op as well as post, it's just common sense. There are no standard guidelines for follow-up, but because of the increased rate or potential for wound complications in the short-term postpartum period, expert opinion recommends early and consistent follow-up. And the data would suggest that a 2-week initial follow-up should be recommended. Next slide. So finally, I think we'll go through these very quickly. The summary of our UAB repair recommendations as resulting from a review of the literature and care bundle would say a thorough examination, including rectal exam for OASIS, should be performed prior to repair. I think many of us have probably seen this. The perineal body may look intact, but on rectal exam, you see a fistula or a hole cephalad to the anal sphincter complex. Exposure and visualization are very important, especially for complicated tears. Don't think twice about going to the OR. The anal mucosa can be closed in either a running or interrupted fashion using sutures as noted. Anal sphincter injury can be an end-to-end, and that should be or overlapping. There's maybe a little bit more little bit more data for advocating for overlapping, but sometimes this just can't be done because of the scarring that's there or the inability to mobilize the sphincter. And certainly a single dose of a second-generation cephalosporin should be given at the time of repair. And next slide. And finally, patients should be screened for pre-existing constipation or risk factors. You can see this at a level C, not really supported by level 1 data, but some benefit has been seen. We recommend a low residue diet so that it keeps the stool formed but soft at the time of healing. Sitz baths, care bottles can be considered. The use of mineral oil, 1 to 2 tablespoons daily, as well as a low residue diet, may help the patient with her bowel movements. Certainly, oral laxative stool softeners should be used to prevent constipation, and bulking agents should not be used a priori right off the bat. Maybe start those a week and a half, 2 weeks later. NSAIDs and Tylenol should be the mainstay of pain management. Narcotics as needed, but be aware of the constipating side effects. An ice pack can be used, and certainly close monitoring for urinary retention is recommended. Next slide. So there's no evidence of an increased length of stay needed because of this. Early and consistent postpartum follow-up is recommended. And the avoidance of digital exams after repair, at least for a couple weeks, is recommended. And finally, next slide. Help is available. If you or someone you know has symptoms after having sustained an obstetric anal sphincter injury, ask your provider, whether that be your generalist OBGYN, for a referral to your gynecologist and/or physical therapist to help address your pelvic floor concerns. Next slide. You all will have these slides at your disposal. I thank you for your attention, and I hope that was helpful. Thank you.
Thank you, Dr. Richter and Dr. Brumfield. We got a lot of questions, so I will do my best to throw them out at all of you and chime in, Dr. Freeman, Dr. Richter, Dr. Brumfield. So I'll start maybe back to Dr. B a little bit here. A couple questions about risk factors came up, and I'm hoping you can maybe rapid fire let us know if these particular things that were inquired about would be considered risk factors. Do you have any opinion on whether epidurals can increase your chances of suffering OAC?
Well, it's well known that if you get an epidural, it can affect the second stage, and it can predispose you to needing forceps. So it's not one of the classic risk factors, but I think it kind of can affect the second stage, and by affecting the second stage, prolonging it and leading to forceps, I think it indirectly can lead to increased OASI.
Okay. Similar question for you. Is short stature something you've seen in any of these studies as being a risk factor?
Very rarely. Very young mothers. I've taken care of, unfortunately, I've taken care of some early teenage girls having babies. And yes, it's a very good idea to inspect their anatomy because they may have a very short perineal body if they have short stature.
And Dr. Freeman, do you want to add?
Yeah, just to say there's a great deal of information regarding that. We've been looking at that specifically as a risk group, and and I know the Scandinavians have shown that to be a very high risk group as well. I mean, some of these shorter women, for some reason, I don't know if that happens in the States, but in our country, a lot of shorter women seem to be attracted to taller men. And there was some
Yes.
evidence to suggest the greater the height difference between him and her, the greater your risk of getting obstructed in labor and ending up with problems, particularly in emergency cesarean. So it's all got to do with how big the woman's pelvis is. If you're
Right.
shorter, the chances are you may have a much smaller pelvis than somebody who's taller. But we don't know that. So people just get a trial of labor. But yeah, there's good evidence to show that short stature is a high risk factor.
Okay, thank you both.
And I firmly believe in assessing the pelvis as part of the physical exam. When it should be done at 36 weeks, but when you come into labor, obviously, you also need to assess the pelvis. Some of these ladies with short stature may have a contracted pelvis and shouldn't be having a vaginal birth.
Okay, that's a great point, and it actually leads me to another question that we received about baby's position. Um, would a provider know before labor, or how quickly during labor would a provider know a baby is in OP position?
So that's a real good question. I used to teach the residents that certainly by the beginning of the second stage, they need to figure out the position. It'd be great to figure it out at 8 or 9 centimeters, but they need to examine and be aware of that. And in the early second stage, sometimes the fetus will auto-rotate to the normal occiput anterior position. But if by late second stage they haven't, then you need to determine if you can intervene and try to manually rotate. And so they need to be actively aware of that in the second stage.
Thank you.
Mhm.
We did get a couple other questions. A lot of people loved the idea because we tend to know what C-section rates are. I know that's something a lot of hospitals keep an eye on by provider. How might we adapt that idea to track OASI by provider, in your opinion?
Well, at our institution at UAB for many years, our quality committee tracked all third and fourth degree tear rates, and we tracked it by provider. We also compared ourselves collectively to the national norm. And so we were actively doing that. And I think nationally that was being done in U.S. hospitals for many years. Now, they change quality parameters over time. So once you achieve a good score on your quality parameters, they tend to change to different ones. So recent years, they changed out of tracking nationally the third and fourth degree tears. We continued to track them, however, in our own group, and we could identify an outlying physician pretty quickly.
And in follow up to your comment, Cindy, we could go through the cases with these outliers, and we could provide education, and they could even get some mentorship where somebody could observe them at the time of delivery, for example, the time of forceps delivery if needed, or at least kind of get an idea of how what they may be doing may be predisposing to this occurring. As a result of this quality measure, we were very proactive in looking at those providers.
And with that in mind, I know this is something that maybe is unique about where you work, if research and quality is something that's very much the culture. So what advice might you have, the three of you, for providers on the call to help cultivate that culture of learning about OASI if it's not something that, you know, if they're just in an OBGYN office and they're not necessarily attached to university or in these maybe studies that research is being done, you know, with what can we do to try to enhance that learning?
Well, I can tell you that at least in the U.S. training programs now, it is emphasized the risk factors and the training for operative vaginal delivery, shoulder dystocia. So that's being emphasized to providers. And I do think our residents in training have to go through workshops to correctly repair a third and fourth degree tears. So it's a big emphasis in training. And so hopefully the younger physicians, if they're trained adequately, they will continue that mindset into their practice.
Thank
Yeah,
you.
it's the same in the UK, very similar. There are lots of training courses for midwives and obstetricians to go to, hands-on on how to repair OASI, but also identification. So there's a lot of good educational material, but yes, it's part of the undergraduate syllabus as well.
Great. Okay. Switching gears a little bit, Dr. Richter, this might be up your alley more. A lot of questions about recovery, aging, and subsequent birth. So starting with some of these recovery questions, how long, if somebody's repair went relatively smoothly in the hospital after a severe third or fourth degree tear, what's a normal timeline for recovery without complication before they should start being concerned, right, about symptoms
Yeah.
lingering?
Well, just like any other wound, you know, there's inflammation, migration, proliferation, maturation in terms of wound healing. And in terms of when you would say you have a mature wound, you wouldn't say that before 3 months. 3 months is kind of, that may be where you consider where you start thinking a wound may be healed. But there's also a little bit of individuality involved as well. Some may heal shorter, in a shorter period of time. Some may heal in a longer period of time. It depends on the size of the repair. There are a lot of factors to consider, but in general, I would say a good 90 days, 3 months. And if you're really, certainly if you're having frank incontinence before then, you should definitely seek help.
And do you have any data on incidence of fecal incontinence for women who've had successful repairs? How common might that be?
Yeah, we actually do. In fact, we designed a trial in the Pelvic Floor Disorders Network. We designed a trial for women having sustained an obstetric anal sphincter injury in their first pregnancy. And they were going to randomize to active pelvic floor muscle therapy versus usual care. I mean, this was my dream trial. This is one I've always wanted to do. And the problem was the incidence rate of fecal incontinence was extremely low in this group of women, young women, first babies, identified third or fourth degree tear, successful healing. Fecal incontinence is very low. Now, one thing we did learn from this trial, so really in the population, probably less than 5%, and this was identified at 8 to 12 weeks post repair. But what we did identify, and it really kind of helped us understand a bit more about this problem, is that there was a marked incidence of flatal incontinence, despite the not having fecal incontinence, but there was a high rate of flatal incontinence, and that a recommendation be made because of this, that when studying these women that sustain these injuries, that they should look at both flatal and fecal, because flatal incontinence as well can severely impact quality of life.
Thank you. And oh, please go ahead, Dr. Freeman, before I
No, I totally
jump
agree.
off
I'm
of that
just
question.
going to make a point that don't forget it's not just incontinence immediately or in the first year after birth. Many of these women may not have symptoms for years, and typically around the time of the menopause, when other muscles that have compensated for some years start to weaken, then they develop symptoms. There's two timelines.
Well,
So that's
sure.
why doing pelvic floor muscle training is so important, even if they don't have symptoms, to try and prevent incontinence when they're around the time of the menopause.
Totally agree with that. I believe in demand for use. The Kegel, initiative. If you're trying to squeeze muscles and contract that muscle, there's a demand for use, the muscle responds. And I agree. I think that's very important to do whether you have symptoms or not. I think the question to me was more around the time at the actual sphincter injury. But I agree, as women get older, and the muscles atrophy and estrogen effects go down, there can also be kind of a secondary level of when accidental bowel leakage can occur.
Thank you. And Dr. Freeman, that was actually going to be the question that I asked as a follow-up to both of you. So thank you. You both hit.
Sorry about that.
No, that's perfect. Thank you. It made my job a lot easier. People were wondering, can flatal incontinence eventually, turn into fecal incontinence? And it sounds like with aging and some of the lovely effects that we might experience during menopause, it certainly could become an issue. As far as subsequent births, so a lot of women experience these tears in their first birth. So folks are asking, is there incidence, is there data regarding a future tear? Is that more likely after you've suffered one tear?
Well, now, this is my opinion, and I'm not sure this has ever been studied. But certainly if you have a previous fourth degree tear and you go through that repair, I'm much more concerned about that in a subsequent pregnancy than if it were like a third degree, a 3A or 3B. But a fourth degree, when you're in a subsequent pregnancy, we don't really know how big the baby's going to be if you go to term. We don't know if you're going to need forceps. There are a lot of events in labor that you cannot predict. So with informed counseling, I would probably err on doing a C-section with that next birth. I would want to review the history and get the labor and delivery chart, look at the op note. But I would want to avoid going down that pathway where we might end up with a subsequent fourth degree tear. I think that's just my personal bias, and that's the way I had counseled patients for years.
I would totally agree with that. Yeah. I mean, the figures that have been given, about 7% of how, if you had a tear before getting another one, compared with 1 point something percent if you haven't had a tear. But I think doing things like anorectal physiology testing to check the pressures in the sphincters, and also to see if there's any defect, if there's been a bad tear that's not been repaired, for example. These are important things, and it helps to counsel patients. I'm sure you have that available as well, as we do. But and then you can have an informed discussion with the patient about the mode of delivery for the next time.
I totally agree. I mean, you're hearing from the OBs there. However, my sense is, even just pregnancy affects the pelvic floor, affects the bladder, affects the anal sphincters. And, we've seen symptoms in women that have had elective C-sections, that have had just totally normal vaginal deliveries. These symptoms occur. And I do think we need to change the mindset and have women, it be a part of their recovery that they do undergo pelvic floor PT. And I think if we put ourselves in the place of these women that sustain a fourth degree, and especially if she's symptomatic and that, or even if she isn't, I think there is some evidence to show that a subsequent vaginal delivery, whether another obstetric anal sphincter injury occurs or not, can be harmful can increase her pelvic floor symptoms.
Thank you. And last question, and I know we've gotten a lot of questions, so don't worry, we'll be adding these to our Q&A page on our website later. So if your question isn't answered live, we will do our best to get the answer back out to you. What would you recommend a person do if they suspect their tear is actually worse than the original diagnosis during delivery? So a lot of times these repairs are happening quickly, things are moving fast in that room. Who should they ask about to see, or how can they get an actual diagnosis post-tear that's accurate?
Well, I guess they could start with their obstetrician, but we would refer that to urogynecology in our practice.
Yeah, we would, and on seeing them, let's say I see her totally intact perineum. She has reasonable squeeze. I don't see any dovetail or gaping at the anal verge, but she has symptoms. I'm going to do an evaluation, as Dr. Freeman noted. I think anal rectal manometry is helpful because there are some standardized levels below which helps you with your differential diagnosis. And certainly doing an endoanal ultrasound can provide some objective data in regard to whether she may have had a good repair, but sometimes with healing, the muscle retracts back, and there may be subsequent defects noted. So just like with any problem, a good subjective evaluation as well as objective evaluation will help. I think that's important because it validates her and it validates her symptoms.
Thank you. And I know our next set of speakers will talk about pelvic floor physical therapy and advocating for yourself when you still have questions. So thank you, Dr. Brumfield and
Right.
Dr. Richter, and thank you, Dr. Freeman, for chiming in. We are going to take a
Thank you.
10-minute break before our next set of speakers. So please be back here at 3:50 to jump right back in, 3:50 Eastern time. So